I think the fear today around racism is there's so much shame about, like, that's not who I am. I mean, unless you're like the blatant racist person, but most people aren't that way. And particularly in healthcare, I do not think anybody enters healthcare with the idea that I'm going to harm somebody because of my own implicit bias. And so when you come at people, you can't be in that place of saying the way you've been doing things is wrong, because all it does is invoke so much shame. And when you're being shamed, what are you going to do? You know, most people get on the defensive. That's not me. I don't know what you're talking about. All this other stuff. It's unpacking that and fully understanding that we all want to be better.
The problem with bias is it's so deeply connected to who we are as a person, our personal identity, that we can't extrapolate out the fact that just like we make a math error, we can make and do make automatic assumptions about people all the time. It's the same thing. It's an error. It's a mental error. And it comes from much more complicated roots, right? Centuries of oppression of an entire people. You know, I mean, I think the obvious fear is saying the wrong thing and one looking like a potential racist person if you're conceptualizing racism as primarily within the individual and not within the system, right? The other thing, and I think everybody feels this, I feel this too, a hesitation sometimes, is not wanting to cause harm to somebody else that is impacted. So, like especially in situations, so there will be situations that I've had with my white colleagues where something will happen and then we pause for a second because it's not clear whether the person who's involved would want us to stop and say, hey, let's talk about this, right? Because now it's a thing. Now we got to talk about it, right? And so there are a lot of nuanced hesitations, I think, that come into play, and some of them are very valid, right? You don't want to fly in with the super cape on and be like, that was racist, we're going to talk about that.
When I teach about racism, oftentimes nurses will say things like, oh, I treat everybody the same. That's not really an issue. In my X amount of years, I have never seen racism. And that may be true because they may not even know what they're looking for, right? But there's this unwillingness to accept it. You know, I recently had a discussion with somebody who had attended one of my presentations about racism. And she said, can you define racism? Which I had twice in the presentation, but I understood from her asking that she needed more, right? She was trying to understand. So, you know, I broke down for her the different types of racism, because one of the other things that Dr. Barbie said is that nurses see our profession as a dyadic relationship. So me and my patient, right? And if I'm not intentionally causing harm to my patient, I can't be racist. And they don't understand the other forms of racism and how that influences healthcare and social environments. And so, you know, I kind of tried to break that down for her and how all of that contributes to health inequities. And her response was, well, why don't you just teach health inequities? And why don't you just talk about inequities? Why do you have to talk about racism? So there's this discomfort around accepting and reckoning with the fact that nursing has a history of harm and of being racist and of not treating everybody the way that they should be. And I think, again, because we're tied to this idea of being the most trusted profession and being, altruistic and empathetic, that we can't reconcile with those. And I think one of the major barriers we have is with recognizing and accepting that racism is a problem and that bias is a problem. And until we can do that at all levels, in practice, leadership, academia, until nurses can collectively say this is a problem and it's my responsibility to fix it, we're going to continue to have challenges. And we'll see nurses who are minoritized doing great work to try and correct those things. But really, the work of needing to correct racism in nursing is from the dominant group, right? And if they don't believe that this is important, it's very hard to make progress. So a big part of what I try to focus on is racism denial, why we deny it, all the evidence that exists, and the fact that we really actually know this is a problem. We just are uncomfortable with moving forward. One of the examples that I give when I teach is, so I'm an emergency nurse, and I say, okay, so I'm in the ED, there are multiple traumas. I just checked the blood with you as a nurse, right? It requires 2 people to check to make sure we don't give it to the wrong person. Somebody distracted me and you saw me pick up the wrong bag of blood and head into that patient room. Are you going to stop me? Everybody raised their hand. Yes, of course I'm going to stop you. Well, what if I'm grouchy and you think that I'm not going to like you anymore? Well, yeah, I'm still going to stop you. Say, well, why are you going to stop me? Even though I might not like you and I might not even want to work with you again, why aren't you stopping me? Or why are you stopping me? They're like, because you could kill the patient, you could harm them. I said, well, the same thing happens with racism and bias. So why aren't you stopping me? Right? We have the same responsibility to prevent harm, whether it's, a allergic reaction or the wrong medicine or whatever. We have that same responsibility. So if I can help them to understand what it looks like, how it shows up, why it's imperative that they take immediate action, then I feel like the disrupting part of it, the solution, is easier to get people to adopt and to address. So if I identify that my colleague is probably providing biased care in this setting, if that is something we do with every patient care, it's no longer a defensive thing, right? It's a learning thing together. It's a growth thing. It's a recognizing implicit bias. And so I think that those types of strategies can really help us to disrupt bias. While I believe the development of cultural competency was well-intentioned, right? We had a predominantly white female nursing workforce that didn't understand other people's cultures, their religions, their beliefs, and that was harming people and providing really suboptimal care. It wasn't, people were not getting dignified care. And so there was an effort to address that and to make sure that nurses take culture into consideration. And that's important. But there are a number of problems with cultural competency. The first is simply the name. You cannot be competent in culture. You can be knowledgeable, you can have humility, you can seek understanding, but none of us could be competent in culture. I'm not competent in the cultures that I exist within. And so it makes this assumption that we can know everything we need to know. So again, we're still dictating care instead of co-creating treatment plans with the people that we serve.
There was established at Oakland Children's Hospital an interprofessional curriculum focused on the pediatric residents, but that anybody in the hospital could participate in. What we found under the label of cultural competence was that people were so invested in their professional competence that it got in the way of the identity work that needs to be done to even give yourself permission to not know, right? So for many of us, since kindergarten, we've been the smartest people in the room. And so when you label something cultural competence, that can have the effect of, oh, I can be good at this, and in fact, I can be the best at this because that's what people are expecting me. And I can do instead of reflect, listen, learn from other people. We had a pre and post knowledge test based on what was going on in a session. And people were just so anxious about what they didn't know. And I remember one person, I think she was a social worker, she had worked at Children's, and by definition in Oakland, for 2 decades. She said, I just feel like I should know this stuff. It was things like that. It was just like, wow, people are so anxious about being competent that we could see how that might undermine your interaction with patients, with families, the very people you need to access for the expertise they have on non-biologic disease-oriented issues.
And I often have white colleagues who'll be like, we talked a lot about checklists, but they want to be like, okay, give me the checklist, what do I do? And there are certain things, right? There are certain approaches. You can approach people with curiosity rather than being accusatory, which is never going to get us where we want, right? And different techniques like that. Say more about that. Why did you think that? What evidence do you have for that? But the real work is internal. And it takes a really long time. And it's, like I said, it's constant because there are so many things. I joke often, I'm like, well, there's 1,675,000 of the things that are racist that I didn't know about until today, right? And it's constant. And I think that we have to be able to see ourselves as having a racial identity and reckon with the fact that we've been, tricked into this system of hierarchy, racial hierarchy as well. That's part of the struggle of the white identity, and reckoning with that is nobody, well, I shouldn't say nobody. Most of us did not ask for this hierarchy, and yet we find ourselves at the top and not knowing how to try to deconstruct that every day.
I just recently looked at a model from a friend of mine, Dr. Notam Opara, that she created in her clinical practice. She's a physician for bias, kind of bias prevention. And it's 3 things. So it starts with a pause of let's talk about this patient. Let's recognize any types of bias that could be involved in our thinking with this patient. Let's look at, any health disparities or inequities that they may be experiencing. And then the next thing is critically interrogate. Is the care that we're providing the standard of care? Are we meeting this patient's need? Is bias being introduced into our care? And I think then, and then the next phase is that advocate, right? So if there is bias, we identify it's not the standard of care, that there are things that could potentially cause this patient harm, we're going to advocate. We're going to do something in real time. And so I think there are really simple things. That's a very simple concept that she's come up with that is really easy to do in practice. You could embed that in practice with every rounds that we do. Every time we give report, we pause, we talk about what bias might be introduced. We critically interrogate what care is being provided. And then if they're not getting the care they should, that we advocate.